I was trying to correct that before opening the webinar, but hasn't been able to be resolved. Anyway, moving speedily along today, since you can hear me and you can see my screen, you don't necessarily have to see my face. So we're going to be talking about onchocerciasis, and I'm very sure that we must all have heard about it, or if we haven't, well, we're going to hear about it today. So this is the outline that I'm going to be using to discuss onchocerciasis today, talking about the introduction, epidemiology, etiology, pathogenesis, clinical features, diagnosis, differentials, treatment, complication, prognosis, prevention. So onchocerciasis is a chronic parasitic disease, and it's caused by the filarial worm Onchocerca volvulus. It's transmitted to humans through the bite of a black fly of the genus Simulium. So that's that tiny fly that sometimes bites people's, on the legs when you're outdoors, and it can be a vector for onchocerciasis. It's one of the recognized neglected tropical diseases, and it's commonly found in sub-Saharan Africa. It usually results in visual impairment and sometimes blindness, and also has quite a number of skin manifestations, which is why we are talking about it today. These can include severe itching, different kinds of rashes, which we'll discuss, discoloration of the skin, and nodules on the skin. And it's often called river blindness because, the fly that, that transmits onchocerciasis tends to live near fast-flowing streams or rivers. So riverine areas are usually the areas that have high prevalence of onchocerciasis. And, these are usually in rural riverine areas. It's also known as Rubble's disease, after one of the scientists that discovered it. And it's the second largest cause of blindness globally after trachoma. So it's the Onchocerca volvulus is a filarial worm. Filarial worms are quite a number. We're going to be discussing a few other filarial worms during the course of this webinar series. Lymphatic filariasis is a common filarial worm. Lymphatic filariasis is a common disease caused by a type of filarial worm called Wuchereria bancrofti, while this Onchocerca volvulus is a cutaneous filariasis, meaning that it lives in the skin. There are others, lower, Manzanella, and those are out of the purview of today's lecture, but it's important for us to have an idea of filarial worms that cause filariasis in human beings. So onchocerciasis occurs in mainly 3 regions, but 99% is in sub-Saharan Africa. There are just pockets of cases in Central America and Yemen in the Arabian Peninsula. But most of the cases are in African countries, as we can see here. Most of these countries are endemic countries, including, our Nigeria, of course. And, in 2017, the estimated prevalence was 20.9 million worldwide, out of which 14.6 million had skin disease and 1.15 million had visual impairments or visual loss. 4 countries in recent times have been able to eliminate onchocerciasis. They're all in South America and Central America. We are yet to eliminate, but one of the reasons why we're having this kind of webinar is to be able to put us closer to the path of elimination. Even though it may not happen very soon, but we'll keep struggling to achieve that. So epidemiology in Nigeria, onchocerciasis was first reported in northern Nigeria in 1908, and studies conducted, over the course of time have placed the overall prevalence at 8.2% in the rainforest area, that's usually the riverine areas, and 6.0% in the savanna area that's further up north. And endemic areas include from the north, extend from the north to the southwest to the southeastern parts of the country. And we have highest prevalence in Zamfara, Kwara State, Enugu, Ebonyi, and Imo State in southeastern Nigeria. So provisional estimates suggest about 7 to 10 million Nigerians have been affected with onchocerciasis volvulus. That's quite a high figure, but over 40 million are at risk of the disease because of being residents or living in areas that have the vector, well, that's the Similium blackfly. And there are about 120,000 cases of onchocerciasis related blindness. So this is a map of Nigeria showing areas where there have been cases. So it's all over, really. You have in the southwest, you have in the southeast, you have in the north, central, and also the northeast, northwest, and northeast. So it's quite endemic, in Nigeria. It's almost every region of the country, in fact, every region of the country. So the disease usually occurs in, it first occurs in childhood between the ages of 0 to 10 years, but it can also occur in adults, young adults, people who are going to the river or the stream to wash or fetch water, and all that. So that may be why you see it more in the active age group, or to fish. Children born to infected mothers may be able to have the infection without symptoms, meaning that their immune system just lives with the onchocerciasis without them manifesting any disease. Now, there also has been shown to be some form of mother-to-child transmission of onchocerciasis. It doesn't have any racial predilection, but it has been observed that the presentation varies from region to region for reasons that are not yet fully understood, meaning that in the forest area, the rainforest area, people have more of onchodermatitis, while in the savanna, the dry areas, people have more of blindness, visual impairments, related with onchocerciasis. There's no sexual predilection, meaning, it can occur in both male and female at equal rates. And those most at risk are those who live and work in streams, riverine areas where the Similium blackflies tend to breed. So this is what the Similium blackfly looks like. That's the only known vector of onchocerciasis. And the main vector is the female blackfly, which, like the female mosquito, feeds on, the blood of humans as part of nutrition for reproduction. And there are different types of Similium blackflies in different regions of Africa. So you have the Similium damnosum, which is the one responsible for transmission in Nigeria and other West African countries. There's the Similium nive in East Africa, Similium onchocertone, and Similium metallicum in Central Africa. And the fly tends to bite during the daylight hours and is found close to riverine areas. Now, this onchocerciasis volvulus has a partner in crime, I would say, called a bacteria called Wolbachia, which is a bacteria that also lives inside the microfilaria or the filarial worm, and helps it, to provide some kind of symbiotic, that's a very useful relationship, which helps it with fertility and survival. So the Wolbachia has also been shown to be implicated in the disease, the disease and the problems that onchocercia causes in the human body. And targeting it as part of treatment has also been found to be very useful in, preventing continuous replication and production of the baby worms or the microfilaria. So It's important for us to know. So it has an assistant or a sidekick. Now, this is the life cycle of the Onchocerca volvulus. We'll just quickly go over this. So it bites, and then when it bites, it can introduce what we call a third stage filarial worm, filarial larva, into the skin of the human host. And then this larvae then, goes into the subcutaneous tissue, that's the tissue just under the skin, and begins to grow and develop into an adult worm. Now, this adult worm will stay in the skin and continue to grow and then begin to reproduce after some time. So you can see that the larvae becomes the adult nodule, and then this then begins to produce the babies, that's the microfilarial, which are the microfilarial worms are the ones that then begin to circulate in the body and can go into different parts of the skin, also into the lymphatic vessels, also sometimes the blood, urine, and sputum. So while it's circulating, a black fly can then bite the human that is infected and become infected again. And when that microfilaria gets into the black fly, it transforms, it moves into the gut, that's the stomach of the black fly, transforms into that same type of worm so that it can, enter into the host again. And that's basically the life cycle. So the vector and the human host. Now, the adult worm, as we saw in that photo, can live up to 10 to 15 years, and some may contain, and sometimes some of the skin manifestation called the nodule can contain several worms, and the female worms are usually very big. You can see that they can grow to a very long length, up to 50 centimeters. And then, of course, the baby worms that it produces, or the microfilaria, also are smaller, much smaller, but they can live for, they live for about a year, before they are either transformed or die, or they die off. And these adults, these worms can circulate in several body tissues and body fluids to cause the pathophysiology that we see, particularly in the eyes and in the skin. So both the adult worms and the microfilaria contribute to the clinical presentation, but the adult worms are generally harmless, meaning that they don't really, aside from the cosmetic disturbance they cause in skin nodules, which we'll see photos of shortly, they don't really cause any other major problems to the host. But the problems come from the microfilaria worms and their sidekick, the Wolbachia bacteria. Those are the ones that cause inflammation of the eyes, what we call onchocercal keratitis, and also skin inflammation known as onchodermatitis. And these symptoms are caused by an immune response, or the body's inflammatory response to the larvae, the dead larvae or the dying larvae. After our immune system kills them off, the dead larvae, or they die on their own, the dead larvae cause severe reactions in the body, which result in the symptoms that we get of itching, which then results in sometimes papules, nodules, and changes. The itching results in, something we call lichenification or hardening of the skin, which is what we, then see as the leopard skin appearance, or, very, very harsh, hard skin, or skin discoloration from constant scratching. And then, of course, the larvae that die in the eyes result in, as we mentioned, corneal irritation, inflammation, and can also affect the retina and the optic nerve, that's the nerve that supplies the eyes, to cause blindness. So the disease manifestation of onchocerciasis varies from asymptomatic to severe. A patient with onchocerciasis could present with Pruritus, that's itching, backache, joint pains, skin discolorations, weight loss, fatigue, insomnia, swelling of the limbs, the groin, and of course the eye symptoms, that's the blindness and or visual impairments initially, which then leads to blindness. So we'll focus a bit more on the skin manifestations. So the skin involvement, typically consists of intense itching, swelling, and inflammation or dermatitis. And there are different kinds of dermatitis or different types of skin lesions that we see in onchocerciasis, depending on when exactly they appear. So the first one that is typically seen is the acute papular onchodermatitis. This is commonly seen in young children, where you have multiple itchy bumps or papules on the skin. And then it's followed by, the chronic or long-term. So when, of course, as you've seen, the worm survives for up to 10 to 15 years. So when a person is infected as a child and does not receive treatment, they continue to have symptoms into their adult, life. And then the itching continues and the papules persist. And then there's darkening of the skin. The skin becomes lichenified. So you have lichenified onchodermatitis, which, is tough, rough skin with increased markings of itching. So the markings of the skin are there. There's excoriation marks as itch marks from itching and scratching. And sometimes the skin becomes broken as a result of a lot of itching and becomes swollen and infected. Then you have edema, which is what we call swelling. So the person can present with swelling of the affected areas, usually the limbs, the arms and the legs. And sometimes you can have it all over on the back and the chest as well. And sometimes it can be oozing fluid and become infected, or what we call impetiginized. So it can present in a variety of ways. Now, over time, due to the friction, the itching, and also the effect of the microfilarial on the skin itself, the skin loses its normal elasticity and becomes loose and becomes, like what we call lizard skin. So rather than being hard, it now becomes soft and, has no elasticity and can be hanging or dangling. That's where the hanging groin comes from, which we'll also have a look at the pictures. Then there is something called the leopard skin appearance, where there is patchy loss of color. This is more common in us dark skinned people. So you have, observe that they have some white patches, particularly on the shin, on the legs, the front of the legs as the shin. You see these white patches that look like what we call vitiligo, but it's not vitiligo. Now, these are photos of onchodermatitis. You can see that it's not so obvious in here, but it starts unassuming with just pruritus, and then gradually the people begin to have tiny papules, as you can see this spot here where the cursor is. So it can start as innocent looking as this, and then gradually spread to this. This is a bit more of a chronic presentation. I can see white patches. This is probably as a result of scratching, and there's early signs of lichenification here. That's increased skin markings. And, it's important for us to know what it looks like, because sometimes you may see this and you want to think of something else called scabies, which we'll also be talking about during this series. And onchocerciasis, onchodermatitis is a very close, it looks quite similar to scabies in some cases. So we must try to learn how to differentiate between the two of them. This is a child with acute papular onchodermatitis. You can see it usually starts on the legs and the arms, which are the areas typically exposed that the flies can bite and all that. So you see these papules, multiple papules here. Some areas are, there's what we call excoriations and some ulceration, probably from itching and scratching. Again, it looks quite similar to scabies, but there are some subtle differences which we'll also discuss. So this is also a form of lichenified onchodermatitis. You can see how the skin looks very old and aged, almost like lizard skin. And on this side, you can see there's extensive lichenification. You can see the lines of the skin, the markings, and that the skin looks quite thick, thickened. You can still see the papules, the spots. Then you see the lines. That's what lichenification looks like. So something that looks like a tree, a bark of a tree. Well, that's what we mean when we say it's lichenified. And you would usually see this in young adults who have been infected from childhood. And there's still very terrible, severe itching or pruritus. The itching or pruritus from onchodermatitis is quite intense and can be, can affect the quality of life quite severely. And you can also see the wrinkly skin here. Now for here, you can look at how the skin has become atrophied. There's loss of the skin elasticity, and the skin becomes shiny and weak, and almost like having the appearance of tissue paper, as they usually say, and it's called lizard skin. Or it can become extremely thick and look like the skin of an elephant. And this usually is chronic, late or long-standing onchocerciasis. By this time, it's usually not very itchy because, you've kind of scratched it to a point where the skin has become almost numb and you are unable to, the person is unable to appreciate the itchy and the pruritic sensation, anymore. So this is how, late-stage onchodermatitis can present. This is what we call the hanging groin, and you can see that the skin is loose. So it's just hanging, dangling everywhere from, the loss of elasticity, and the skin has become thin or atrophic. And then sometimes there's also inguinal lymph nodes. The lymph nodes here are quite enlarged and are hanging. The lymph node enlargement could be from the constant scratching, which causes infections, and in the skin, which then results in enlarged lymph nodes. And also in people who are chronically infected with the onchocerciasis worm, it causes lymph node enlargement because remember, we said the microfilaria moves around in the lymphatic vessels. So that can also cause some degree of inflammation there. This is the leopard skin that I spoke about. So patchy skin. Sometimes you see like white patches right in front of the legs that look like either that the patient maybe suffered burn injury or some kind of injury. But in many cases, if there's a risk of living in a black fly endemic or onchocerca endemic area, you have to think of onchocerciasis. And this is not usually itchy because it's a long-standing complication. And, in some cases, in some communities, this is used as an indicator of prevalence of onchocerciasis. So in some rural areas, if you see a lot of elderly people or middle-aged people with their legs having this discoloration, you want to think that, okay, this is an area or a place where onchocerciasis is quite prevalent. This is also the same picture as you can see, the leopard skin. And here it's even extending all the way to the back. So this is usually caused by the chronic scratching that occurs with onchocerciasis. So scratching over years and years and years will actually damage, the outer layer of the skin or the epidermis and cause loss of pigment. Now, finally, we have the nodules. So these are, pockets of the large worm Remember, we said the worm is really large and long, 50 centimeters in length. So it curls around and causes nodules on the skin, as we can see here. And these nodules are usually asymptomatic, and just underneath the skin surface, involving the deep dermal layers and the subcutaneous tissue where the worms like to live. And that can be seen, commonly. It's not everyone that has onchodermatitis that will develop this, but where you suspect it, you must search for it or look or check other parts of their body for these onchocercal nodules. And this is what we call Sauda. Sauda is unilateral lichenification and darkening of the skin. And it's a type of localized onchocerciasis or onchodermatitis. So if you see a patient having this kind of clinical presentation, you should think about onchodermatitis. So in differential diagnosis, we're talking about scabies, as you mentioned. So in scabies, what you want to do is the pattern of distribution. Pattern of distribution can be similar to onchodermatitis, but scabies has a predilection for the webs of the fingers. So in between the fingers, if you are seeing the papules more in those areas, in between the fingers, the wrists, and then the armpit, and the groin. So onchodermatitis would be on the groin, but you're not likely to see the papules, the tiny spots in between the fingers. So that's one way you can distinguish between scabies and onchodermatitis. And then other family members are most likely to be affected by more likely to be affected by scabies than onchodermatitis. So if you have such papular rashes, very itchy, worse at night, and then everyone in the family is scratching, it's more likely to be scabies than onchodermatitis. And of course, if they don't live in a region or an endemic area for onchodermatitis, it's unlikely that it will be that. It's more likely to be scabies. Now, senile atrophy is something that occurs with age. Thinning and of the skin can occur with age, but by the time you're seeing atrophied skin in someone that's not that old, you begin to wonder, why would this occur to the skin so early? And the skin is itchy and they're having this appearance. You want to consider that. And usually the senile atrophy in onchodermatitis may be limited to one area. It may not be generalized. Whereas if it's age-related, it may actually be, generalized. Now, eczema is also a very common, or atopic dermatitis, a very common differential. We don't have much of atopic dermatitis in rural areas in Nigeria, though. So if I see a child that I'll be thinking of eczema in a rural area, I would want to think of onchodermatitis first. And that's because it can also present with like acute papular onchodermatitis with the itching and the papules and oozing of the skin lesions with fluid and all that. But in onchodermatitis, this will not be in the same sites or location as eczema, and may be limited to like the buttocks or just the two forearms. And so you may be able to distinguish. Another common differential is papular urticaria, insect bite allergy, which a lot of children have these days, but it's also slightly different. There's some differences. Papular urticaria is unlikely to go all the way to the buttocks, unlike onchodermatitis, which usually, would be, will go all the way to the buttocks and the trunk. Usually papular urticaria you only have on the arms and the legs. We spoke about lichenified eczema. Now, lower is a differential of eye onchocerciasis, because in lower you can also have the eye worm, similar to onchocerciasis, and it's also a microfilarial problem or disease. So, like I said, hypersensitivity reactions, insect bite allergy, papular urticaria, atopic and contact dermatitis are also differential diagnosis of onchocerciasis. Now, ocular manifestation usually is the first, it's usually asymptomatic initially, and the first sign of infection is to see the worm in the eye. So some people may come with a complaint that they saw a worm in their eye. And if you look at the eye with the slit lamp examination, you might be able to see the worm there. But when that worm or the microfilarial begins to move into other chambers of the eyes, the anterior and the posterior chambers, it can then cause a lot of damage to the eyes, cause the acute inflammation, that's punctate keratitis of the eyes, and then can cause inflammation of the optic nerve, which is the nerve that supplies the eye. And then, of course, it can now lead to blindness. So this is what the eye worm looks like. The eye worm is quite, can be quite terribly looking and alarming for someone who, you're in the mirror, and then you just see this worm across your eye. It can be quite distressing, but sometimes you have people who notice this and come to the hospital saying they saw a worm in their eye. So this, you have to, think of both lower and onchocerca. And it's very important, onchocerciasis is very important to distinguish between the two, because the treatment is slightly different. So for investigations, the gold standard is a skin biopsy, skin snip, not skin biopsy, skin snip. So we snip just the surface of the skin. And this is usually, you can raise the skin up and snip a little bit of it, then place that tissue in some normal saline for about 24 hours to allow the microfilarial to emerge. And then the microfilarial can be identified microscopically. So that's usually the gold standard for diagnosis. And usually this skin snip is performed over the iliac crest, the scapula that's around the upper chest, the scapula, and the others, the upper back, sorry, and then the lower extremities, so the legs. So those are areas where you can take a pinch of skin. And usually it is advised that one takes up to 6 snips so that you can have the best diagnostic sensitivity. If you take just one of it, you may miss it. But if you take 6, you're unlikely to miss, the worm 6 times. So the other things are blood tests, when usually what you're looking for is eosinophilia. The eosinophil count is typically higher when there's onchocerciasis. And sometimes you may also have a high neutrophil count if there's secondary bacterial infection. We've also observed that the ESR of the patient may be high because of the chronic inflammation that it causes. There are other tests, but are not really done so frequently. The antibody test, there are various antibodies, but since they do not distinguish between active and past infection, they are not very useful. Then there's an antigen test, which is being developed. This may become useful in the rural setting because it will be like a point of care test, like a kit where you can put urine or tears, and the onchocerca antigen can be tested, whether it's positive or not. But of course, it's not fully available, or it's not really available in our environment. Maybe in the future, it may be made available so that there can be better monitoring in areas where microscopy may not be feasible or possible. There's also DNA testing using the nucleic acid amplification test, and polymerase chain reaction testing can be done to isolate the DNA. Other tests, not so useful, may just be for research or clinical purposes. Ultrasound scans can be done to reveal the nodules, to show that, these nodules are actually onchocercal nodules. Then there's slit lamp examination for keratitis and retinitis. And sometimes there's what we call a patch test with DEC, which is no longer done because of the severe allergic reaction that it could cause. But it used to be a test in the past to put some DEC topically on the skin, and it causes a reaction, a skin reaction in response to the dying microfilaria, and this can confirm onchocerca, but it can also cause severe allergy, so we don't do it anymore. Treatments, the drug of choice is ivermectin, and we also add doxycycline for 6 weeks. Remember that I said that there is a sidekick called Wolbachia, is a bacteria that helps the onchocerca to be very fertile and reproduce a lot. So the ivermectin kills the microfilarial worms, while the doxycycline kills the Wolbachia bacteria. And also the doxycycline also has an effect on the adult worm, so a mild effect on the adult worm. The ivermectin does not have any effect on the adult worm, but it will kill the microfilaria, that's the tiny worms or the baby worms. Albendazole sometimes is added to the treatment, but it's not the standard treatment of choice. Now, before now, diethylcarbamazine, which is DEC, was also used in the treatment of ivermectin, but it was found that it can accelerate the development of onchocercal blindness. So it's really been, the recommendation is that it should no longer be used. Though I know some people still use it, but it must be used with caution. If indeed it's going to be used with corticosteroids, but it's best to use the drug of choice, which is ivermectin. And so the combination of ivermectin and doxycycline will be able to disrupt, the continuous reproduction of the microfilarial worms. They may not be able to get rid of the adult worms, but over time, the adult worms may also die. So treatment with ivermectin can also cause some mild symptoms associated with the death of the microfilarial worms. And these, include itching and, just some discomfort, slight fever for a short while. But after that, it clears off. It doesn't, however, cause any worsening of eye symptoms unlike the DEC, which is why that was stopped. So treatment with 6 weeks course of doxycycline kills more than 60% of the adult female worms and sterilizes 80 to 90% of the females after 20 months of treatment. Now, doxycycline does not kill the microfilaria, so it cannot be used alone. So doxycycline must always be used in conjunction with ivermectin, to kill the microfilarial worms as well. Other treatments being developed or found in developing countries include moxidectin, suramine, and amokazine, but not readily available here. And the ivermectin is found to be very effective. It's only when maybe for some reason ivermectin is not working that suramine may be considered, but because it has multiple toxicities, systemic toxicities, it's not really recommended. Now, onchocerciasis is one of the conditions that can be treated with mass drug administration. And WHO recommends, in onchocerciasis prevalent areas, that ivermectin is given at least once yearly for about 10 to 15 years to be able to eliminate Onchocerca volvulus from people living in that community. So contraindications to this for this treatment to ivermectin: children under 5 years or less than 15 kg, pregnant women, lactating mothers, or infants of less than 1 week old, and severely ill patients. So where people have co-infection of Onchocerca volvulus and lower, there has to be a treatment, the treatment has to be adjusted, because ivermectin in lower can cause fatal encephalitis, that's inflammation of the brain, and which can lead to death. The reaction of the dead lower worms can cause a very major inflammatory reaction that can affect the brain. So it's very important to be sure that the person doesn't have lower before administering ivermectin. So the treatment, as we mentioned, the dosage usually we give 150 milligram per kg orally, just a start dose every 6 months. Some people say once a year is fine, but we just want to be sure, you can have some stubborn worms that refuse to go. So you want to give every 6 months, or some people that the drug fell on the ground. So 150 microgram per kg would come to, if the person is like an average adult is 70 kg, then you have something like 10 milligrams of ivermectin. So that's probably about 3 tablets of 3 to 4 tablets once every 6 months. The tablets are usually 3 milligram tablets. And I think in Nigeria, ivermectin is given free of charge for areas that have onchocerciasis. So this drug is provided freely by the government, I think sponsored by some NGOs and the WHO. And then, of course, the doxycycline. The doxycycline probably is not free, but it will be important to prescribe it along with the ivermectin for better treatment. This is the ivermectin being given to a child. So by the time they calculate, you give the dosage that is required. So other forms of treatment, surgical care, and then, of course, supportive treatment. So then those nodules can be excised or removed surgically and, combined with treatment with ivermectin and doxycycline. Then for the itching, you want to, relieve the patient's suffering, because the itching from onchocerciasis can be really terrible. So keratolytic preparations can help with the very thickened skin, the lichenification. So things that can soften and gently peel the skin, like sulfur salicylic ointment or urea ointments or creams. For the itching, you can give an antihistamine like loratadine to relieve the itching. And of course, to prevent dryness of the skin, reduce the effect of skin atrophy, emollients like Vaseline, shea butter, coconut oil can be useful. And if there's evidence of infection, we also give antibiotics for a short period of time. So these are some long-term complications that are not so common, but can occur with onchocerciasis. Nodding syndrome, which is a rare form of epileptic seizures characterized by nodding of the head, followed by some form of dropping as the head just, keeps nodding and dropping. And such people can also have some psychiatric manifestations like wandering behavior, aggression, depression. And then there's Nakalanga syndrome, which was first described in Uganda for children who have been affected by onchocerciasis from a very young age. It can stunt their growth and cause some form of dwarfism, and can cause some degree of mental retardation. Of course, other complications, mentioned blindness and death. So treatment with ivermectin every 6 to 12 months for the lifetime of the adult worm, which is about 12 years, is what is recommended. And this can result in resolution of early lesions in the eyes and the skin. However, patients that have already developed cornea, chorioretinitis, blindness, skin atrophy, and skin depigmentation, that's the leopard skin, will not improve with treatment. Those are more permanent manifestations or complications. And it's known to shorten the lifespan by about 4 to 10 years, particularly with patients with blindness. So no vaccine, but there can be vector control with insecticides, protective clothing, insect repellent sprays and creams, and mass drug administration with ivermectin. And then, of course, educating people in the endemic area so that they get prevention treatment early before they develop any of the long-term complications of the skin or the eyes. And there have been several control programs to eradicate the disease from Africa. They have been successful to an extent, but have not been able to, completely eradicate disease, but have reduced the burden of onchocerciasis. So we need to do more. We need to have more mass drug administration programs to further reduce, the prevalence of onchocerciasis and to work towards elimination of the disease. So in conclusion, onchocerciasis is one of the NTDs of public health concern in Nigeria. It has the capacity to be eradicated, particularly because it has cheap and available treatment and has mass drug administration, can be treated with mass drug administration. So it's transmitted to humans through the exposure to repeated bites of the infected black fly. And the symptoms include severe itching, disfiguring skin conditions, visual impairment, and may include permanent blindness. And the treatment of choice is for onchocerciasis is ivermectin. So these are my references, and I want to acknowledge my resident who helped me with the slides. And thank you very much for listening. So
thank you so much, Dr. Cole.
Yeah, so we'll open up for question and answers. And
thank you for the Dr. Cole, can you hear me? Can you guys hear me?
Yes, we can hear you very well. Thank you, Dr. Cole.
Okay. So I didn't want you to continue moderating since you just finished presenting. So that's why or would you continue?
No, go ahead, please. Yeah, go ahead so I can catch my breath.
Exactly. That's what I was trying to do. Well done. That was an amazing presentation. Thank you very much, all 159 people, okay, minus myself and Dr. Cole. So all 157 people on this. In spite of the election, everybody are waiting results. We all showed up. Thank you so much for attending. And so I have answered a lot of the questions. So Dr. Cole, if you look through the question and Q&A segment, you will see that a lot of the questions have been answered. So, but if there's anyone that is not answered yet, Dr. Cole, can you just take a quick, rundown of the questions there? Because my network went off, so I got logged out at the time, and I think I didn't answer the question on leopard skin, lizard skin. I didn't answer that question. Apart from that, I think then the YouTube channel, because they were all talking about how to get the presentation. And I told them there's a YouTube channel where we usually, like a link, where we usually put it up after the presentation. So maybe if you could just comment on one or two questions that are left. And thank you for the amazing presentation. It was really lovely.
Thank you very much. Okay, thanks. I've seen a question from Chinwendu Wigwe, who is asking, what's the pathological difference between Sauder, elephant, and lizard skin? So with Sauder, there are more of there's no pathological difference. It's more of a clinical and chronological difference. When I mean clinical, the presentation, Sauder usually affects one limb, and usually it's the limb that has been primarily infected with the adult worm that is affected. So if the adult worm is hiding in maybe the left leg, it's more likely that that leg is what will develop, the lesions that we saw at Sauder. Let me see if I can go back to the photo that I put of that. So you would see that it's a unilateral darkening of the skin and rashes. So usually it may present this way if that limb is, where the onchocercial nodules may be hiding out. So it's more likely to be affected with the microfilarial worms and the Wolbachia than the other limb. So that's that. But these microfilarial worms still circulate around the body and can cause itching. The lizard skin is as a result of the itching. So you have thickened skin. Lizard skin and elephant skin are almost the same thing and are associated with chronic infection with onchocerca. So that's essentially, the difference between them. Elephant skin and lizard skin, probably very similar. It just shows that skin is rough, dry, wrinkled, and thickened. So the YouTube link, I'll try to paste it, but I try to add it at the post webinar email, but I'll add it here now. Try to get it out and add it here. And is it infectious apart from the bite? That's Ebola Bameke. Is that Dr. Bameke that I know? So no, you cannot transmit onchocerciasis from one human being to the other without the aid of the black fly, which is why I said it's unlikely if you have a whole family having, onchocerciasis, having itching and rashes, you're more likely to think of scabies because it's unlikely that everyone in the house will be bitten by the same black fly to have, the disease at the same time. So other than being bitten, just like the way malaria is only transmitted via mosquitoes, onchocerciasis is only transmitted via the insect bite, the Samelium bite. So what is the appropriate treatment for the nodules? So with the nodules, the treatment usually is excision. Or have you answered that, Dr. Shaki? I'm not sure.
I haven't.
Well,
my network went off again, but I haven't.
Okay. So the appropriate treatment for the nodules usually is excision in combination with the drug treatment. So the drug treatment will not get rid of the nodules or the adult worm, but it can be removed surgically. That's the main treatment. So the YouTube channel, I uploaded them on my personal YouTube channel. I will post a link here so that everyone can see. Great presentation. Thank you. You're most welcome for those who are thanking for the presentation. So we don't usually give the slides, but we can watch them on the YouTube channel. So you can just, go through the slides on the channel if you need to, go through them. So how do we differentiate between lower and onchocerciasis? So now, clinically, this might be a little bit difficult, but there are some clinical symptoms, or not really, because lower does not give the severe pruritus and papular dermatitis that onchocerciasis gives. So lower usually gives eye worms and swellings of the limbs. So you just have swellings, what we call Calabar swelling. Just notice that some parts of the limbs are swollen, but onchocerciasis gives you an itchy rash. So if the person is complaining of eye worms, but doesn't have any other skin lesions, like what we call craw, on the body, you want to think more of lower than onchocerciasis. So in that case, when you are treating, you don't treat with ivermectin immediately. You may want to treat with albendazole first, to reduce the lower because ivermectin will give a very terrible reaction if there's a high load of lower in the blood, lower microfilarial worms. But we'll still discuss that a bit later. So what happens when the patient skips the drug for a few years? You start counting all over. Well, typically, yes, because as we mentioned, the adult worm lives up to 15 years, so you want to make sure that you give the drug for the lifespan of the adult worm. So if the person misses some of the drug, you may still want to be sure, because it means that the adult worm may have had the opportunity to produce new worms, and then you are still having new worms from the date when they stopped. So that may be, you may want to do that and make sure that it's given for 12 years at a minimum. Yes, we can get the YouTube link. Is it possible to have partial swelling instead of an asaka seen in both legs up to the stomach alone? So usually we not have an asaka in onchodermatitis. You would have mild or minimal swelling, and what we call you may also have some oozing of fluid if it's secondarily infected. But the swelling usually is the inflammation from secondary bacterial infection due to the constant scratching. Our nails, as we're scratching, we're introducing some bacteria under the skin, which will then cause infection. But you're not likely to see an Asaka in onchocerciasis. Does ivermectin, is it available in the market? So yes, it is available in the market, but it's essentially a free drug. And in most local governments in Nigeria, it can be given free. If you make a diagnosis of onchocerciasis, the person is meant to be treated free of charge with ivermectin. But I know that it's also available for sale, and it's not very expensive. So in the South where we are, we're able to buy it when we need to buy it. For other things, we also use it for scabies. So for scabies, it will not be given free, but you can buy it in a pharmacy. So it is quite available. I'm not sure of the availability in the northern part of Nigeria, but I think, let me ask Dr. Abdullahi. Is Dr. Nafisat on the call? I'm not sure if Dr. Nafisa is here or she's gone off. Dr. Nafisa, are you here? Or is she not enabled? I think I enabled her to be a panelist. I'm so sorry. I thought that I had done that immediately restarted the presentation. My apologies, Doc. So let me know if you can. Are you enabled as a panelist now, please?
Good evening, Dr. Cole. Good evening, Dr. Gold. Good evening, participants.
Good
Welcome.
evening.
Thank you for the excellent presentation. We have ivermectin. It's available. It's you can buy it, and I'm not sure of the getting it for free in the what do you call it, NTD programs, but I'm sure that patients can buy the tablet of ivermectin. It's fairly available.
Okay, and I think it's affordable too, Cole?
Yes, it's not that bad. I think somebody mentioned, was it 700 or something? I think
Okay.
At least I think 2 weeks ago I wrote it for a patient and he got it. So,
Okay.
and I've had several occasions whereby patients get it. It's
Yes,
available.
I think here they sell it. One tablet is like 100 naira, So if you want to give 3 or 4 tablets, that's about 300-400 thereabout. But it is available, but it's supposed to be free. I know that there's a program. We'll still discuss that and see on the NTD program. People with onchocerciasis and elephantiasis, that's lymphatic filariasis, they are meant to have access to free ivermectin, actually. So somebody said, I met someone who is full blood count happened to have elevated eosinophil count with associated swelling from both legs upwards towards the upper abdomen just before the chest region. So in that case, you may need to also check for microfilarial worms. You could also consider, loasis there, but there could be several other things that could result in, that presentation. Also, you want to check, the kidneys. Sometimes if a person had been taking something that maybe has caused what we call acute tubular necrosis to the kidneys, that could be the presentation. So there are many things that you want to also check for in such a patient: extensive investigation, further history and examination. And of course, if you are not too clear on what you think it is, you can refer that patient to a teaching hospital. So Ali Laila is asking, is the prevalence of onchocerciasis more common in rural than urban areas? Yes, it is. We have more in rural areas, in rural riverine areas. Now, there's a lot of rural-urban migration. So we are seeing a lot more patients in the urban areas with onchodermatitis and onchocerciasis, because maybe when they were young, they used to live in a rural area, but as they, grew up, they moved to the city or the urban areas. But generally, it's more common in rural areas, but it's not impossible to see cases in urban area. We do see cases walking into a clinic in Lagos from time to time. For research purposes, which is more preferable, epidemiological studies or MDA? So epidemiological studies they're both important, because one is to identify the prevalence, and the second one is to help the quality of life. So you can't do a study and leave it at that. You must intervene. You must have an intervention for the people. These are human beings. If you know that there's, but you cannot intervene until you do epidemiological studies. So both of them, go hand in hand, because if you are going to make a case for mass drug administration, you need to be able to, identify that it's needed in a particular community through an epidemiological study. So the difference between onchocerciasis and scabies by location. Yes, I mentioned scabies has a predilection for the hands and the webs of the fingers, the webs of the toes. So usually when a person comes with scabies, those are the first suspected scabies rather. Those are the first place that I would check. I would check the in between the fingers. I would check the wrists. I would also check the axilla. I'll also ask when the itching is worse. Usually scabies itching is worse at night. And if any other person in the house is also having similar rashes or itching or a close contact. So that will probably clinch the diagnosis of scabies over onchocerciasis. So does the government still supply ivermectin? I believe so. Should be well-branded to distinguish from other brands available in community pharmacy. Well, the truth of the matter is that ivermectin has multiple purposes. So I know that community pharmacists may still need to sell. For instance, scabies is more common than onchocerciasis, and scabies is not covered for free treatment under the NTD program. So I believe that community pharmacists should still stock ivermectin for other purposes. But for the filariasis, I think it's meant to be given free. So, someone said 20 naira per tablet. Oh, that's really good. That's quite available. 50 to 100 naira. Yeah, 50 to 100 naira is what I know. So yes, the NTD program distributes ivermectin free. Yes, I believe so. Thank you, Dr. Afolayan. Yes, there is free ivermectin. I know that in Lagos, although we have been taken off the register because we hadn't reported for some time. But I know in Ogun State, some of our patients that live in Ogun State, they're able to get ivermectin free at the health centers in Ogun State. So it is available. So maybe we could try in our centers to refer people to probably the Ministry of Health, I presume, to get it. But since it's so cheap, I don't know whether the transport fare to the Ministry of Health will be even greater than just walking to buy the drug. But anyway, it would be good to still report it, because we also need to remember that it is a reportable condition. So it's good for us to be able to, send the data whenever these cases are seen to the Ministry of Health or the nearest local government, so that it can be documented. So treatment with doxycycline, ivermectin done for a period of 6 months. No, doxycycline is for 6 weeks, while ivermectin is every 6 months. So doxycycline treatment is given for 6 weeks and stopped. It's a one-off treatment for 6 weeks. But the ivermectin treatment is meant to be for 6 months for up to 10 to 12 years. So can anything be done after 15 years? Daniel Egamba is asking, we had a 40-year-old patient presented with hyperkeratotic scaly lesions in the clinic, yet to be investigated. Well, the truth of the matter is that if it's chronic onchodermatitis, usually you cannot reverse, the effects of chronic onchodermatitis, but you can manage them. So a lot of emollients, we usually tell people, use lots and lots of emollients. Vaseline is a common emollient, cheap Vaseline jelly. Shea butter is also a common emollient. If it's very hyperkeratotic, we give sulfur-salicylic acid ointment to help to kind of descale the scales. So those are what we do to manage that. So that can improve the appearance, but it's not going to clear it completely. And patients need to be counseled about that. That is not likely to, your skin is not likely to go back to normal, but with the treatment, it will be better. Nothing is displaying on your screen. Sorry, Chukwemeka Annie. I think it might be your network, because I know you complained you couldn't see the slides earlier, but I think it may be a network issue on your side. Maybe you can try going out and coming in again. Yes, Mectisan is the brand of ivermectin. Yes, Mectisan is the brand that is, I think, donated by Merck and is available, in the national NTD program. So where children cannot take doxycycline, yes, children cannot take it because it can cause discoloration of their teeth. And you want to avoid doxycycline in children less than 10 years. So I'm not sure what they can take, but what I think we probably would do is give, so in many cases where doxycycline cannot be taken, they give azithromycin. But in some cases, I'm not sure if azithromycin may be effective. We may just need to wait out the childhood phase, give the ivermectin, and then later on, when they're able to take the doxycycline, they can take that.
Yeah, correct, Dr. Cole. It's just not as effective, but that's what they give, or clindamycin.
Yeah.
Yeah. So
thank you. Thanks so much. So someone is saying there is free distribution, that's Rukaya Abdul Kadir, free distribution of ivermectin in onco-endemic communities is enough. Yes, I believe so, during mass administration. So that's why reporting is important, because if your community, you are seeing patients with oncodermatitis, but you don't report, they will not be captured in the national NTD program. And that free MDA treatment may not be accessible for that community. So it's very essential that we're able to recognize the symptoms and signs of oncodermatitis and make reports so that the public health authorities, the NTD program can investigate and include that community in the free drug distribution when they're having the MDA programs, wherever you are in the country. Yes, ivermectin is available free in PHCs in Lagos State. That's true. Although at one point we had to start begging them. They said we were not reporting cases, so they removed us. But I think they've put us back. So, all right, I think I've answered most of the question. Okay, this is very important. I have seen cases like this in Badagry. I think we can sensitize people over there, especially the ones with elephantiasis who believe it's caused by spiritual attack. Yes, a lot of people with this generalized itching and rashes, they think it's spiritual. So we don't need to go into the communities, engage community leaders and talk to them. Those that are in public health in people amongst us should try to do this more frequently. To educate the community leaders, people who can talk to the people. If it's coming from the doctor, they may not believe. They'll just say, oh, doctor is just saying their own. We know that it is a spiritual thing. But if you are able to convince community leaders, religious leaders, to speak to people about these things, then they're more likely to believe, so that when they do develop it, they can come to the hospital for treatment and not just go for spiritual treatment in quotes. So that's also very essential to note. Yes, so somebody is asking, I think this is the last one we'll take. What form of treatment can be offered to a patient who has been on ivermectin for 2 years for oncodermatitis, but still complain of generalized itching? Have you included the doxycycline to that treatment? So I would recommend that you give another dose of doxycycline. Make sure you're giving the optimal dose of ivermectin. If the generalized itching is still there, you may need to consider other differential diagnosis in such a patient. Unless you have hard tissue confirmation of onchodermatitis, it could actually be something else. So you want to consider other possibilities in such a patient. If the patient did not have doxycycline, you may want to also give that as well. So I think we've come to the end of this. Thank you very much for everyone. So just a reminder, okay, let me try and get the link so that I can upload it to the Q&A box. Now, just a reminder about the apps that we are working with. If you do have a case, or you can actually upload, let me see if I can open it here. So this app that we have, you can actually upload the app, a photograph of something you think is onchodermatitis. And I think it will come, for now, that photo will come to me or one of the other facilitators. So this is the Denser app, and you can actually send in a photo to this app and just give it a try and see if it works. We're still developing it, so but it should work. I mean, if you try, you can just put a little history, the name, the age of the patient, take a photograph and send it, and we'll get the photo, and we can then say, okay, yeah, this looks more like, onco, or this looks more like scabies, and we can try that out and see how it goes. Also, if I would advise you download the Skin NTDs app, WHO Skin NTDs app on your phone, and you can use that as a guide. If while you are working in the hospital, it will help you, guide you to the kind of lesions that you are looking for, particularly with the skin NTDs, either it's onchocerciasis, leishmaniasis that we spoke about last 2 weeks, and you can watch the replay of the webinars on the YouTube channel. So that's also there. So I'm just going to upload the YouTube link, and I think we can call it a day for today. And then I'll also try to send it with the post webinar email that usually comes in. I think most people will get that email. So if you check in that email, you would get a link to the channel and the videos that the previous videos. Okay. So I don't know if anyone has any other questions, comments before we round up, but I think we can round up now. Dr. Gold, is there any other thing that you'd like to say or share? Hello? Hello? Can you
Hi,
hear me?
Dr. Cole. I'm right here. Yeah, I can hear you loud and clear. I think we all can. Thank
Okay.
you so much.
So I'm sending, if you check the chat, I've sent the link. Maybe I should enable the whiteboard so you can just click on it, but I sent it to the chat.
The chat is not there yet. It's not on the chat. Did you put it on the chat or the Q&A?
I'm sorry, I put it on the Q&A. Okay, I've put it on the chat now. So you can just, that's the link to the last webinar we had on leishmaniasis. You can just open that and then subscribe to the channel so that whenever we upload other videos, this one should be uploaded by tomorrow. You can watch it, and you can also see all the videos in case someone missed the previous one. You know, I know a lot of people would have missed today, because we have like half or a third of what we had in previous ones for obvious reasons, but they can always watch it later. So I'll just leave it on for another 1 or 2 minutes so that people can just copy the link, and then we'll call it a day. So yeah, I wanted to talk about photography, how to take picture, because we're encouraging you to take pictures and send to that app, but we need you to know how to take good skin photos, which a lot of people don't really know how to do. So it's very important when you're taking a skin photo to take it in very good light, preferably daylight, or if you can just face a very good light source, or and then take the photo. Try to take very close to the lesion. We don't need the whole face, or we don't particularly don't want to have any identifiable features. So we don't want a person's whole face or a ring that can be identified. Usually it should be a part of the body that if I see it, I will never be able to know who it is, and as close to the lesion as possible. And also, you want to have a good background or back, don't just take it, with things in the background. So you can put a paper, like a brown paper, or, a white, no, not white, because you want it to be darker. So like a brown paper, or a cloth, or a blue cloth, or a brown cloth, or a green cloth, and put it behind or at the back of the body part you're taking a photo of, and then try to take a photo with good lighting as close as possible. So of course it shouldn't be blurry. If it's blurry, please take it again. And if as much as possible with a good resolution camera. So that's how can take good photos. So we want to try and inculcate teledermatology as part of this project in the little ways we can. And then this can also help confirm some diagnoses, and also help with reporting to the relevant health authorities. So thank you very much, everyone, for attending. We'll call it a day, and we'll have another webinar in 2 weeks' time. We hope you'll be able to attend and invite others who may be interested. Thank you so much, and have a blessed week.
Thank you, everyone. Thank you very much.
We wish Nigeria all the best. Let's all embrace peace. And, we thank God for everything. Okay.
Thank you, Dr. Cole. Thank you, everyone, for attending.
Yeah.
Bye.
Bye-bye.